everyone, I'm Priyanka and I'm currently pursuing my PhD at the Queen's Cancer Research Institute. For the past 3 years, my research has been centered on investigating bladder cancer. In the next 25 to 30 minutes, I'll briefly go over the disease and who gets treated with BCG upon getting a diagnosis for bladder cancer. I'll be discussing what BCG is, a little bit about its history and how it came into existence, who developed it, and how it was introduced for treatment of NMIBC as an immunotherapy, and what we know so far about its mode of action. I'll also talk about Verity BCG. According to the Canadian Cancer Society statistics, in 2023, close to 13,400 patients were diagnosed with bladder cancer in Canada, and almost 20% of these patients were predicted to die from it. And this is a massive increase from 2017 when this number was just 9,000. Bladder cancer patients usually present with blood in the urine, and the diagnosis begins with a direct inspection of the bladder and involves cystoscopy. In this procedure, the urologist inserts a small narrow tube called a cystoscope, which has a lens which basically allows a detailed examination of the inside of the bladder. And a biopsy, meaning a small piece of tissue, is removed to collect a very small sample using a special tool to send for lab testing to confirm if there is a cancer. And before undergoing any kind of surgery, imaging and urine sample tests are performed for further confirmation of the disease. So shown in this figure are the different stages of bladder cancer, and based on the depth of tumor invasion, it can be broadly categorized as non-muscle invasive and muscle invasive bladder cancer. And when it comes to treatment of non-muscle invasive bladder cancer or NMIBC, papillary tumors are resected, and even after best possible resection by the surgeon, the risk for recurrence is still very high. And to test how bad the cancer is, additional tests are performed by a pathologist to confirm the grade, which tells us about the cell abnormality, and the stage, which helps us identify the spread of the cancer. So a low-grade tumor usually grows more slowly and is less likely to invade the muscular wall of the bladder than is a high-grade tumor. And a high-grade tumor grows more aggressively with increased likelihood of spreading to the muscular wall of the bladder and other tissues and organs. And the decision to use intravesical BCG is made using a risk stratification criteria. So for low-risk patients, generally a single post-operative mitomycin or gemcitabine chemotherapy is used. And for intermediate risk NMIBC, an induction intravesical chemotherapy or BCG immunotherapy is suggested. And this group of patients is a bit heterogeneous, and therefore the decisions are made carefully by taking into account several other factors. And for high-risk NMIBC patients, intravesical BCG is used. So we've been talking a lot about BCG and how it's being used as an immunotherapy for NMIBC, but what is BCG actually? So BCG happens to be the most widely used vaccine in the world, with over 100 million children getting vaccinated every year. In fact, 2021 marked the 100th year of BCG for prevention of tuberculosis. And tuberculosis, or TB, is a disease which affects the lungs, lymph nodes, and other parts of the body. And majority of TB cases are caused by the bacteria Mycobacterium tuberculosis. And BCG is derived from Mycobacterium bovis, which commonly infects cattle and other animals. And BCG is made by weakening the Mycobacterium bovis bacteria such that it does not cause a disease, but it can still prompt your immune system to wake up. And as you may have heard, that I've been using the term immunotherapy with BCG, and it basically refers to any treatment which is being used to prompt the immune system to attack the cancer cells. It was two extremely patient physician scientists, Dr. Calmette and Dr. Guerin at Pasteur Institute in Lille, France, who grew this bacteria under special conditions, the condition being a combination of potato slices and ox bile. So they grew this bacteria for 230 passages over a period of 13 years before they declared that this new weakened organism was actually safe to be used in guinea pigs, cows, horses, hamsters, mice, and rabbits. And in fact, it also provided protective immunity to these animals when it was challenged with the disease-causing Mycobacterium tuberculosis. In the first reported human inoculation, this is even before the first ever reported vaccination, they actually injected a man with 44,000 bacilli intravenously, and the bacteria was described as not harmful. Subsequently, in July 1921, the vaccine was first administered to an infant for the first time because the infant's life was in danger as the mother had been suffering from TB, and the infant was saved by the vaccine. So, this followed a series of successes and some failures as well before BCG vaccination actually gained trust across the world. Obviously, the news about the success of BCG was spreading quite fast in rest of Europe, given that the number of tuberculosis cases was increasing at an alarming rate. And the first documented distribution of a daughter strain was BCG Russia or Moscow, which was obtained in 1924. And from 1924 until lyophilization was possible, that's after 1,173 passages, in 1961, BCG Pasteur continually underwent serial passages, with daughter strains being obtained directly or indirectly at irregular times, and only a few are being documented. And this technique, lyophilization, refers to drying the bacteria for long-term storage and also making sure that we are able to restore its capabilities. But overall, there was a global interest in introducing BCG to countries with a high prevalence of TB cases. And the introduction of BCG faced several challenges. For example, even identifying who should be vaccinated and how could consistent manufacturing be ensured. Because it was not a chemical product but a living organism, and to be effective, it has to be kept alive or revived to a live state to at least some extent while dealing with the changes that the bacteria is undergoing. Because as we know from the recent pandemic, that these microorganisms are constantly evolving as we witness with the SARS-CoV-2 variants. And you may have appreciated that what has been effective with COVID vaccination is the preservation of a specific part of the virus that our body will still recognize and respond to it. And so came the use of Pfizer and Moderna. And this principle applies to all vaccines where you want it to generate the necessary immune response when the actual infection occurs, but you also want to make sure that it does not cause disease upon injection. So when we talk about BCG, we often hear different names associated with it, like BCG Thais, the Connaught, Russia, Moscow strain. And BCG is actually the name given to the whole family of vaccines that were first derived in 1921 through a 13-year-long effort to take away the disease-causing ability of the bacteria called Mycobacterium bovis. And all of these different names of the current day BCG have been given to over 1 billion people, most of whom are babies. And a lot of research is of course ongoing to make BCG better so it can provide longer term benefit in the TB scenario. And the name of places associated with BCG preparation, although may create some confusion, but they actually help the scientists to compare the ability in providing the desired level of immune response, be it specific against TB causing bacteria or non-specific like in cancer, where the BCG is helping the cancer fighting arm of our immune system. And any discussion on the treatment of NMIBC, non-muscle invasive bladder cancer treatment, cannot begin without mentioning Dr. Morales, who was the first to conceptualize and initiate the use of BCG for treatment of NMIBC. But before we talk about the use of BCG in bladder cancer, I wanted to highlight that the knowledge of using microorganisms and for their anti-cancer property actually dates back to 2600 BC, when infection was induced to actually treat tumors. And in 18th century, most studies were led by Dr. Coley, and he showed that the bacteria-derived toxins, they're commonly referred to as Coley's toxins now based on his name, and he found that they have an anti-tumor effect. And all his work basically pointed towards using bacteria or their products to treat cancer. And initial findings on these toxins remain controversial because it was unheard of, and also there was a lot of variable results in clinical trials during those days. But the first evidence that BCG may be effective against cancer actually came from a study where it was observed that autopsies from those who had TB had a lower incidence of cancer. In early 1970s, when studies were actually being conducted in multiple animal models and human trials to actually look at the BCG efficacy in cancer such as melanoma with as high as 90% response, that led to a lot of enthusiasm. And some early studies also showed that neonatal BCG vaccination actually prevented childhood leukemia. And large randomized controlled trials were being conducted in lymphoma, colon cancer, ovarian, lung, and melanoma, but it did not lead to any significant improvement. And so the enthusiasm for BCG use slowly started fading away. So the question obviously comes up, why NMIBC when it didn't perform as expected in other cancer? And the basic principle that Dr. Morales thought about for use of BCG for NMIBC was that BCG should be in close contact with the tumor. So if you look at the dose response curve for anti-tumor response to BCG in animal model, it was seen to be bell-shaped, which means that excess of BCG could actually reduce the response and in fact even promote tumor growth. So an optimal number of viable mycobacteria was required to gain success in the treatment. And they found from the guinea pig model that as much as 10 to the power 8 organism is enough is a sufficient number for optimal success. And effective BCG immunotherapy also required a tumor which was capable of initiating immune response and trafficking, as well as a host who is able to produce normal immune response on being stimulated with foreign microorganisms. And luckily, all of these conditions can generally be met in patients with bladder cancer. So Dr. Morales initiated the early trials of BCG for bladder cancer in around 1972, and through several subsequent trials, this treatment gained a worldwide acceptance for bladder cancer, while immunotherapy trials in other malignancies were abandoned. And ever since then, it has remained the gold standard treatment for patients with intermediate to high risk NMIBC. So BCG has been in use for the treatment of patients at intermediate to high risk NMIBC for over 45 years now. And following the first report by Dr. Morales about the efficacy of BCG in NMIBC, Dr. Donald Lamb, a urologist from United States, actually introduced a 3-week schedule of maintenance dose for 1 to 3 years. And in reality, not all patients actually get the full dose, and treatments often get suspended to reduce side effects, and there are a lot of patients who also show intolerance to BCG. But when BCG is recommended for intermediate risk NMIBC, an induction regimen, which is weekly instillations for 6 weeks, is followed by a 1-year maintenance therapy, which is weekly installation or for 3 weeks at 3, 6, and 12 months is usually recommended. And when we look at the treatment regimen for high-risk NMIBC, there is an induction BCG therapy followed by 3 years of maintenance, which includes weekly installation for 3 weeks for until 36 months. And that has been the standard of care for reducing the disease recurrence and the progression rates. So how does BCG work in bladder cancer? Because we have a great understanding of how it works as a vaccine for TB, but how does it really work in initiating anti-tumor response against NMIBC? And BCG-induced non-specific immune stimulant in bladder cancer is still not very clear. And here's where we actually have to differentiate between the mechanism versus mode, since it's a therapeutic indication in cancer scenario. And while our understanding of the mechanism of action of BCG has significantly advanced, scientists are still trying to understand the actual mode of action of BCG so that the response rates can be improved. Compared with BCG vaccination, the number of bacteria given for intravesical therapy is orders of magnitude greater. That is, for vaccination, we use 10 to the power 6 bacilli versus for bladder cancer, we use 10 to the power 9 bacilli, which is a significant increase in the number of bacteria which is given for therapy. And BCG also induces a somewhat complex immune response of innate and adaptive immune response, resulting in cell-mediated tumor-specific killing of urothelial carcinoma cells. And it's challenging to study both specific and non-specific effects in a laboratory system because when used in humans, our body actually encounters both live and dead bacteria and is equipped to respond to both in different ways. And this cannot be completely studied in a controlled environment. So that was about the history of BCG and how BCG may be mediating its favorable effects in NMIBC. But of course, we want the response to be better than what they are so far. And a major issue that patients and clinicians are facing or have been facing starting in 2012 was the shortage of BCG. Sanofi Pasteur, the BCG manufacturing company in Canada, had to shut down a plant because of an unfixable mold contamination issue in the facility. And this led to a huge shortage of BCG for patient needs. And unfortunately, several patients received reduced doses of BCG. However, this problem did not last for very long, although we've still not completely fixed it. Because recall when I mentioned about the distribution of different BCG strains and the names that I described earlier. So BCG Russia Moscow happens to be one of those early strains that was distributed. And currently, India uses both an early strain, that is BCG Russia, and a late strain, BCG Denmark. And Verity BCG is basically that BCG preparation which is approved by Health Canada in 2021 for use in NMIBC treatment. And this product is manufactured at the world's largest vaccine manufacturing facility called Serum Institute of India. And in 2021, Health Canada actually approved it as an adjuvant therapy after transurethral resection of the bladder tumor for primary or relapsing superficial urothelial cell carcinoma, stage being TA or T1 without cyst. And it's also been approved for TA grade 1, that is at a high risk of recurrence. Of course, no compromises on the established dosing schedules were made, and it remains similar to previously used immune cyst from Sanofi Pasteur or the currently used Oncotype PrEP from Merck. So after establishing BCG's anti-tumor efficacy, several researchers have questioned about the strain differences and oncological effectiveness of certain BCG strain. And today there have not been any conclusive evidence from clinical trial on the superiority of one strain over another. And S1602 is an ongoing National Clinical Trials Network study. And in this 3-arm trial, eligible patients include men and women with BCG naive high-grade NMIBC, including CIS, TA, and T1. So what are the current new developments to enhance BCG immunotherapy? One such is genetically modified BCG, which has been designed to improve the safety and more effectively stimulate and modulate the immune response, and it's been produced with modern technology that can meet modern regulatory expectation, and it has the potential to not only improve, but it can also elevate the chronic supply shortage. So it was in Max Planck Institute in Berlin that they have developed one such recombinant BCG called as VPM2001, which is currently undergoing clinical trial in bladder cancer patients who have failed the standard BCG. And the preliminary results from this study actually shows a lot of positive response with safety and efficacy of the recombinant BCG. Another encouraging development is the development of systemic immunotherapy pembrolizumab, which is now approved for NMIBC when other intravesical treatment has failed. There is randomized clinical trials still ongoing for these alternatives. But it's important to note that the establishment of BCG as a standard of treatment for over 45 years now has actually helped in the current and future treatments, because they're all building on the past lessons. That brings us to the question, how can you help in this common goal? Well, the foremost thing is take care of yourself. That's the most important thing. Improve and pay attention to your quality of life, including your diet and regular exercise. Quit smoking. That's such an important point which cannot be emphasized enough. And when possible, provide a detailed history. Discuss about your gender, your past infection, vaccination status, smoking. So this will all help researchers to relate any such factors with disease behavior and response to BCG, and participate in discussions on research needs question and clinical trials. And lastly, advocate for research as well as funding in bladder cancer to help reduce this financial burden. And lastly, I would like to acknowledge Dr. Morales and Dr. Lam, who have been the pioneers of BCG immunotherapy for bladder cancer, and a special thanks to all the research lab, collaborators, patients who've been involved in advocacy for research and funding, and Bladder Cancer Canada. So, as we draw our discussion to a close, allow me to share an inspiring anecdote. Dr. Morales received a heartfelt letter of gratitude, as you can see here, from a woman who had actually undergone successful treatment with BCG therapy. But what makes this story truly remarkable is that the woman is none other than the daughter of Dr. Guerin, the physician scientist who co developed the first BCG vaccine in 1921. So, this heartwarming connection highlights the enduring impact of medical research and the profound difference it can make in people's lives across generations. So, in closing, let us remember that the stories of perseverance, innovation, and human connection within the field of medical research inspires us to continue pushing the boundaries of knowledge and strive for better outcomes for all. And on that note, I would like to end this webinar. Thank you.